Hello, everyone. It's my pleasure and my honor to welcome you tonight to one of our weekly online series. On behalf of the Educational Board of the Mega Medical Association and the Egyptian Society of Anesthesiology, I would like to welcome our second speaker, Dr. Ahmed Hegazy. Dr. Hegazy holds MBBCH Master Fellowship of the Royal College of Physicians of Canada and Master of Public Health. He is currently an associate professor in anesthesiology and critical care medicine, University of Western Ontario, London, Ontario, Canada. Dr. Hegazy is going to speak to us tonight about focused transthoracic echocardiography in critical care. Dr. Hegazy, you are welcome to start.
Thank you very much, Dr. Ahmed, and thank you everybody for having me. This is my first time on Mega Learning, and I look forward to participating. The attendance is very good today, and I'm pretty excited at this opportunity, so thank you for having me. So today I'm going to be giving a talk on focused transthoracic echocardiography in critical care. This topic is a big topic, and this lecture is going to be a little bit of a fast-paced lecture where I'm going to be going through a lot of images, a lot of guidelines, and hopefully I'm hoping that everybody gets something out of it, whether you are experienced with point of care ultrasound or not. I hope there's something in it for everybody. So I don't have any financial disclosures to make. In terms of the outline of my talk, I'll start off with a brief introduction, and then I'll go through basic image acquisition, and then we'll finish off with clinical vignettes that will highlight the utility of point of care ultrasound. So in terms of what instruments we have to make diagnoses in the ICU, we know that the stethoscope's been around for more than 2 centuries now. And then in the 70s, the PA catheter came into existence, and it gave us good information about filling pressures, cardiac output, vascular resistance. However, they are invasive to put in, and they can be associated with complications like PA rupture. And then in the 90s, the technology of ultrasound started developing. And ultrasound initially was not a small portable machine. It was a very big machine that you had to go into a room and you had to be immersed in water actually to get an ultrasound done. But with the technology advancement, it currently can be as portable as a handheld cell phone device connected to your probe. So in terms of examination protocols, there are multiple transthoracic or focused transthoracic echo examination protocols that are available. And if you look into it, you'll find that there's quite a few protocols. There's the ACES protocol, which is the abdominal and cardiothoracic evaluation with sonography in shock. There's the global ultrasound check for the critically ill, which is the Gucci protocol. There's the RUSH protocol, which is the rapid ultrasound for shock and hypotension. There's the focused cardiac ultrasound protocol, which is the name endorsed by the American Society of Echocardiography and the American College of Emergency Physicians. Another name for the same thing is basic/advanced critical care echocardiography, and this is the name that is endorsed by the American College of Chest Physicians. So all of these will include 5 basic views, and we'll go through these in a second. In the year 2010, the American Society of Echo published a consensus statement on focused cardiac ultrasound in the emergent setting. And this was a consensus statement between both the American Society of Echo and the American College of Emergency Physicians. And the emergency department was one of the first areas to adopt point of care ultrasound. For years, obviously, the technology was restricted to cardiologists in terms of at least focused echoes. But then when emergency department physicians started using it, it became more widespread, and it's now really an integral part of emergency medicine practice. For a lot of modalities to reach the mainstream, you need a publication sometimes in the New England Journal. And so this review article was published in the New England Journal in 2011, and it was basically a review article that discussed the utility and the applications of point of care ultrasonography across different specialties. And you can see here, it covers pretty much all specialties you can think of. I even see dermatology on that list. And it basically lists all the potential ultrasound applications for each specialty, and critical care is on that list, where we use ultrasound for procedural guidance, pulmonary assessment, and focused echocardiography. This consensus statement is the statement that we have adopted here in Canada for the most part, and there's also a Canadian version of it. But this statement was put forward by the American College of Chest Physicians in the year 2009, led by Dr. Paul Mayo and his colleagues. And it broke down critical care echocardiography into two domains: basic critical care echocardiography and advanced critical care echocardiography. Today, we'll try to, as much as possible, cover basic critical care echocardiography. All right, we'll move on. Basic image acquisition. So this should hopefully be a review for some, maybe it's new for others, but I'll quickly go through the basic image acquisition steps. So first of all, the transducers that are available to us. We're all familiar with the linear probe, and the linear probe is a high frequency probe. It's about 5 to 10 megahertz. And because it's a high frequency probe, it gives you very good resolution, but it gives you a limited depth of penetration because ultrasound waves attenuate very quickly, especially if they are in high frequency. So we use linear probes obviously for line placements because of they give us the depth that we need and the resolution shows us the actual needle and the needle tip. It can also be used for pleural interrogation, airway exam, and gastric exam in peds. The curvilinear probe, on the other hand, and the phased array probe, both of these are actually low frequency probes. So 2 to 5 megahertz is their average frequency. And because they are low frequency, you are able to interrogate greater depths of penetration with both the curvilinear and the phased array probe. You see here that the depth of penetration can be 36 centimeters and above with the curvilinear and the phased array probe. Now, the phased array probe, another nickname for it is the cardiac probe, is the probe that we use for cardiac exams. So focused critical care echo will be mainly using the phased array probe, and this is predominantly the probe that cardiologists will use for their echoes as well. And the reason is it's a small footprint probe, so it fits very nicely between the ribs. However, I will warn you that the phased array probe, there's a trade-off with the phased array probe. It has a very high frame rate, so it's excellent at detecting objects in motion, like valves of the heart. So because its frame rate is very high. But the trade-off there is that its line density is lower. So the line density it gives you better spatial resolution. The curvilinear probe has greater line density than the cardiac or phased array probe. And the reason I say this is when you're trying to, say, for example, do a pericardiocentesis, the needle tip is not visualized with the phased array probe. You cannot see the needle tip with the phased array probe because it has a lower line density, unlike the curvilinear probe. With the curvilinear probe, you'll be able to see the needle tip very well. And so, say, for example, if you go to, want to drain a loculated effusion, and you want to see your needle tip, then the curvilinear probe will show you your needle tip, whereas the phased array will not. So how do cardiologists confirm positioning of the needle? They use agitated saline and inject air bubbles and make sure that they can see the air bubbles in the pericardium because the needle tip cannot be visualized with this phased array probe. However, this is the probe that we will be using for our focused echo. I want you to pay attention to the index mark. The index mark will always correspond to the dot on the screen. If you have an echo machine or an ultrasound machine in general, once you switch it to cardiac mode, notice that the index mark will be on the right-hand side of the screen. If you switch it over to any other mode, say, for example, you switch it over to abdominal mode or you switch it over to vascular scanning, you will notice that the index mark will switch over to the other side, to the left-hand side of the screen. Why is that? It's because the radiology convention is the opposite of the cardiology convention. The cardiology convention is that the index mark's on the right-hand side, as we see here right now, whereas the radiology convention, the index mark is on the other side. So notice that next time you're using your machine, once you switch modes, how the index mark will switch to the other side. It's because basically cardiologists and radiologists did not really agree on that part. So the 5 basic views are included in most protocols that we use for focused echoes. And these 5 basic views include the parasternal long axis, the parasternal short axis, the apical 4-chamber, the subcostal 4-chamber. The first part of that name refers to where your probe is situated on the chest. So if your probe is sitting in the parasternal area, then you say it's a parasternal view, either long or short axis. If your probe is sitting on the anatomical apex of the heart, then you'd call that an apical forechamber. If you're in the subcostal area, you'll call that a subcostal forechamber or subcostal IVC view, depending on your probe orientation and your object of interest. I usually start in the parasternal area and move clockwise. So I start at point number 1, parasternal, go apical, and then go subcostal. In terms of image optimization, the best position to have the patient in, if you're doing parasternal and apical views, is left lateral decubitus. And with left lateral decubitus, the heart becomes more anterior in the chest wall, and it makes it easier to visualize the heart. However, if you are trying to get a subcostal view, the best position for the patient in a subcostal view is supine with the legs bent at the knees so that the abdominal muscles are relaxed and you're able to exert a little bit of pressure underneath the costal margin. Parasternal views, we'll go through them quickly here. We've got a parasternal long and short axis. The parasternal long axis is the first view I usually start with. The probe is situated in the 3rd or 4th intercostal space, just adjacent to the sternum, just off to the left of the sternum. And the index mark is pointing towards the right shoulder. You notice here the arrow, the index mark is pointing towards the right shoulder. This is the only view out of the 5 basic views where the index mark is pointing towards the right shoulder. All the other views, the index mark is either pointing to the left, or in case of an IVC, it's pointing straight up. But the only view out of the 5 basic views where index mark is pointing to the right shoulder is the parasternal long axis. So what do you see on your screen? So here in the parasternal long axis, you see the right ventricle in the near field up on top of your screen. The right ventricle is the most anterior structure of the heart. So it's always in the near field when you're doing transthoracic echoes. They say the fastest way to a man's heart is through his right ventricle. It's because the right ventricle is most anterior. The left atrium, on the other hand, is the most posterior structure of the heart. And so by contrast, if you're doing a transesophageal echo, you'll notice that the left atrium is always on top of your screen in the near field. So because we're in a transthoracic approach, the right ventricle will be now in the near field, more anterior. And then just below it, you'll see the left ventricle. In the far field, you'll see the left atrium. Between the left atrium and left ventricle, you'll see the mitral valve. And then you'll see the left ventricular outflow tract, the aortic valve, the aortic root, and the proximal ascending aorta here as well. This is what this view will look like. Again, these are all the structures that we're looking at. One structure that I did not point out so far is the descending thoracic aorta. So in the far field, you'll see the circular structure, which is the descending thoracic aorta. This is an important landmark because if you're trying to discern or differentiate a fluid collection that's you see in the far field, say you see a fluid collection and you're not sure whether that fluid is a pericardial effusion or a left pleural effusion. Remember, you're on the left side of the chest, so it could be a left pleural effusion as well. The way to differentiate is by looking at the descending aorta. If the fluid is tracking anterior to the descending aorta, between the descending aorta and the heart, then it's obviously a pericardial effusion. If the fluid is tracking posterior to the descending aorta, then it is a left pleural effusion. And let's look at this view here. So this is a parasternal long axis, and we see a hypoechoic fluid collection in the far field, and we see the descending aorta. Where is the fluid tracking? It is tracking posterior to the descending aorta, so this is a left pleural effusion. It is not a pericardial effusion because if it were a pericardial effusion, it would have tracked anterior to the descending aorta. Here, on the other hand, we see a fluid collection that tracks anterior to the descending aorta. You see it here in part of the cardiac cycle. And so this fluid collection is a pericardial effusion. I want you to bear in mind that when you are doing these exams, it's important to cut the chamber of interest in its true diameter. So try to make sure that you capture the chamber of interest as big as it can be. So essentially, what I'm trying to say here is avoid the cylinder effect. If you're cutting through a cylinder right in the middle, it'll look like it normally is. It'll look like its normal size. But if you're off axis, if you're off to the side, you will foreshorten that cylinder and you will cut it at a false diameter, and it will look smaller than it actually is. And so when you are doing focused echoes and when you're trying to get a parasternal long axis, you should be able to tilt your probe back and forth until you make the left ventricle look the biggest it can be on the screen. So the way to avoid the cylinder effect is to basically tilt your probe back and forth until you see the chamber of interest, which is here, the left ventricle, look the biggest it can be on the screen. If you tilt over a bit and it starts looking smaller, that means you're foreshortened. You tilt back again, it looks the biggest. You stop right there, you hit acquire on your machine, and that's where you want to capture it. You don't want to foreshorten your left ventricle. What do we use our parasternal long axis for? We use it to assess gross LV size and function. We use it also to assess pericardial and left pleural effusions. And here we also see very clearly the mitral valve and the aortic valve. So we can assess mitral and aortic valve morphology from this view. Now, it's important that when you're assessing valves, the first step of assessing any valve is a good 2D examination. So a lot of us, when we're first starting to do these, we want to jump to do color Doppler and all the fancy stuff. It's important to not jump to anything before you actually get a good 2D examination of the valve and assess whether the valve looks normal or not, whether there's prolapse, whether there's a flail leaflet, whether there are vegetations or perforations of the leaflet. So a good 2D examination is the most important first step in any valve interrogation. And here in this view, we can assess the mitral and the aortic. And you can also assess the RV size, although it's not the best view to assess RV size because it's usually cutting just the right ventricular outflow tract in the near field. I usually go to the apical four-chamber or the subcostal four-chamber to assess my RV size. All right, so let's look at this parasternal long axis view. Two abnormal findings that jump at us looking at this view. The first abnormal finding is that the left ventricular systolic function is severely impaired. You can see here that the contractility is very poor. The second thing you see is that the aortic valve is very calcified. You see here how it's not opening very well, how it's very hyperechoic. So this is a valve that I would be interested in measuring gradients across to see what degree of aortic stenosis there is, because this patient is most definitely going to have some degree of aortic stenosis based on how that valve looks. Now, one thing I want to turn your attention to is, as I said, a 2D examination is crucial in assessing valves. And it's been looked at specifically with regards to the aortic valve. If you see the aortic valve leaflets to be thin and pliable, and you see them to open well, so by open well, I mean the opening should be at least 8 millimeters and above. If you see the aortic valve leaflets are thin, pliable, and open well, and the leaflets do not look calcified, then this actually rules out severe aortic stenosis with about 99% sensitivity. And that's been looked at by this group here, Yukio Abe. So essentially what I'm saying is, look at the valve. If it looks normal, then it's unlikely that the patient has severe aortic stenosis. If it looks abnormal, then the patient will likely need further interrogation. All right, moving on, we have a parasternal short axis view. The parasternal short axis view you get by basically rotating your probe so that the index mark is now pointing to the left shoulder. Notice here you're on the exact same spot on the chest. You have not moved anywhere at all. You stayed on the in the parasternal area in the left, third, or fourth intercostal space, just adjacent to the sternum, and you've just rotated your probe 90 degrees so that your index mark is pointing towards the left shoulder. And here you will cut the left ventricle in short axis. The left ventricle here will look like a donut, and you will see the right ventricle usually between 9 o'clock and 12 o'clock. So here it is, parasternal short axis. The nice thing about this view is that you're cutting the left ventricle at a plane where you can assess the walls, the anterior wall, the septum, the inferior wall, and the lateral wall. The full name for that is a parasternal short axis mid-papillary view, because you're usually trying to cut the papillary muscles at a mid position. And here, let's just identify the walls. This is the anterior wall of the heart, right on the top in the near field. And then here you see the septum between the right ventricle and the left ventricle. In the far field, you see the inferior wall of the heart. And then laterally, you see the lateral wall. So here you can assess the anterior septum, inferior, and lateral walls of the heart, all in the mid segments, all in one view. So if you're assessing wall motion abnormalities, this is an excellent view for that purpose. And this is the intraventricular septum right there, and that's the right ventricle. All right. So in terms of applications, the parasternal short axis view is used to assess global and regional wall motion abnormalities. So global LV systolic function and regional wall motion abnormalities, as we mentioned, you can assess from this view. You can also assess volume status if the papillary muscles appear to be touching with each systole. We call this kissing papillary muscles. That means the patient is likely volume depleted and will likely be volume responsive. And so the kissing pap muscles, another name for that is end systolic effacement, meaning that the walls are effacing at the end of systole. You can also assess for right-sided volume overload or pressure overload if the septum becomes flattened. Notice here in this image that the left ventricle looks like a donut or looks like an O, the letter O, it's round. If the septum starts to flatten, the left ventricle will start looking like a D, and the D, the flat part, will be the septum, and that would indicate right-sided volume or pressure overload. You can also assess for pericardial effusions in this view as well. So here, an example of a parasternal short axis view. One thing that jumps at us from this view is that the contractility is very poor. We see here that this is a severely depressed LV with very poor systolic function. And furthermore, you can actually say that this poor systolic function is global. It's not regional, it's basically the entire heart is globally hypokinetic. Compare it with this view here. I'm not sure if you're able to see it well, but on my screen, I can see here that at least the inferior wall seems to be doing something. It seems to be contracting, it seems to be thickening a bit, whereas the anterior wall seems to be more hypokinetic. So this patient has some anterior wall hypokinesia. The septum, there's acoustic shadowing we can't see, but we can see at least the inferior wall, and it's contracting a little bit better than the anterior wall. And there's another application for the parasternal short axis. We mentioned that the ventricle normally looks like a D shape, an O shape, I apologize. It looks like an O shape. Here the septum is flattened. Here you see that the septum is starting to look like a D. And so a D-shaped left ventricle or a flattened septum, as we've said, indicates right ventricular volume or pressure overload. Moving on, we're moving on now to the apical four-chamber view. With the apical four-chamber view, we move our probe over to the anatomical apex of the heart, the point of maximal impulse, where the apex of the heart is. And that's usually in most people about the fifth intercostal space, anywhere from the mid-clavicular, around the mid-clavicular line, sometimes a little bit more lateral, sometimes a little bit more medial, depending on where your apex is. Your index mark here is pointing towards the left shoulder. So your index mark is now still pointing to the left, and you're cutting the heart from the apex upwards. And so closest to your probe in the near field, you'll find the left ventricular apex. And in the far field, you will find the left atrium, and between them is the mitral valve. And then you'll also find the RV, the RA, and between them is the tricuspid valve. So the left ventricle is a bullet-shaped structure. Normally it looks like a bullet shape. The RV, on the other hand, usually looks more triangular. And this is an intuitive view. You see all four chambers of the heart in this view. So this is what it looks like. And note here that the apex of the heart is normally formed of the left ventricle. So you see the left ventricle here normally forming the apex of the heart, the left atrium in the far field. Between the left ventricle, left atrium, you see the mitral valve. Between the RV and the RA, you see the tricuspid valve. So what do we use this view for? The applications of this view include using it for relative chamber size and function. So we can assess RV size and RV function from this view. And you can compare RV size to LV size. Normally, the RV is less than 2/3 the size of the LV. If the RV is greater than 2/3 the size of the LV, that would indicate RV enlargement. And then septal kinetics you can assess if there's a pericardial effusion as well. And the two valves that you can see in this view are the tricuspid and the mitral valve, so you can assess their morphology from the apical four-chamber. All right, an example here of an apical four-chamber. We see here how the right ventricle is pretty small and triangular, more triangular in shape, whereas the LV is more of a bullet shape. And you see here that the LV actually is not contracting very well. I would actually say that this LV has some degree of systolic dysfunction, but I would confirm it with other views. So I would go to the parasternal short axis and see whether I can confirm that there is indeed LV systolic dysfunction, but this view looks like there certainly is. And then the RV here looks normal. The RV size looks normal. It's less than 2/3 the size of the LV. Contractility certainly looks good. The tricuspid annulus has a lot of excursion. This is one of the ways to assess RV function is looking at the tricuspid annular plane systolic excursion. How far is the tricuspid annulus moving up and down with each systole? And it seems to be moving quite adequately here. Compare it to this view, on the other hand, where you see a huge RV. The RV is very big on this view, and it's actually encroaching on the apex. You see now how the RV is starting to form the apex. And so this is a patient with severe RV enlargement, likely due to acute cor pulmonale, could be due to a massive pulmonary embolism. So here, the RV is severely enlarged, and there's clearly a degree of an acute, evidence of an acute cor pulmonale. All right, so this is an apical 4-chamber view. And what I want to turn your attention to here is the mitral valve. Now look at the mitral valve, and as it closes, I want you to see how it behaves with each closure, with each systole. The mitral valve will normally close during systole, and you see here that as it closes, there is some entrainment of that anterior mitral valve leaflet into the left ventricular outflow tract. So focus on the arrow there. You see how the mitral valve is actually curling back on itself, and the anterior leaflet is getting entrained into the left ventricular outflow tract. So this is what we call systolic anterior motion. And that could be a cause of dynamic left ventricular outflow tract obstruction, which is what we see sometimes in patients with hypertrophic cardiomyopathy and sometimes in patients post-mitral valve repair. Okay, moving on, we have the subcostal 4-chamber. And with the subcostal 4-chamber, we have moved our probe down underneath the costal margin, under the xiphoid process, and the index mark is now still pointing to the left side, pointing to 3 o'clock, to between the left shoulder and left elbow. And we're underneath the costal margin, just underneath the xiphoid process, looking at the heart from underneath. And the unique aspect of this view is that you're actually looking through the liver. You're not looking through lungs. You're not looking through, you're not negotiating the lungs, essentially. You're actually looking through the liver. The liver here is your acoustic window. And this can be an advantage. If you have a patient who is on positive pressure ventilation, on high PEEPs, for example, you can find that it's challenging sometimes to get apical views or parasternal views. And a lot of times it's because the lungs are in the way if you're on high PEEPs, for example. And so you'll find that if it's difficult to get an apical or a parasternal, a lot of times you'll find that it's easy to get a subcostal 4-chamber because you're not looking through the lung at all. You're actually looking through the liver in this view. And you can see here, you see the RV, the RA, the LV, and the LA. And so the RV is closer to the liver. And you note here that it looks like an apical 4-chamber, except that it's tilted over about 90 degrees or so from an apical 4-chamber. But it shows you all 4 chambers, hence the name subcostal 4-chamber. So this is what it looks like. Again, in the near field, there's the liver, there's the RV, RA, between them is the tricuspid valve, there's the LV, LA, and between them is the mitral valve. We use this view as an alternative to the apical 4-chamber view, and we can assess with it a relative chamber size and function. Say you're not able to get an apical 4-chamber, then you can go to the subcostal 4-chamber to assess how big the RV looks and compare RV and LV size and function. And you can also use this view to assess for pericardial effusion. You can assess this, you can use this view in the middle of a cardiac arrest as well to do a sono pulse check. The nice thing about this view is that it's underneath the costal margin. It's away from all the commotion happening at the chest if somebody's doing chest compressions. So you can actually situate your probe and get ready to get a good view. As soon as they pause chest compressions for a pulse check, you can assess what the RV and LV are doing And so that would be the sono pulse check. And that's the only situation where I usually start with a subcostal 4-chamber. But if I don't get a subcostal 4-chamber, I'd have to move up to the apical or parasternal. Obviously, that would take up a little bit of time. And so if the CPR is on hold, you have to be really quick. All right, so what do we see on this view? So here, there's a subcostal 4-chamber view. You're looking through the liver. The RV looks normal in size. There's the RA. The LV looks very, very sad. So in this view, you see how the LV contractility is severely impaired and it's not doing a whole lot. So this is severe LV systolic impairment. This is a sono pulse check. So now you're doing half an hour of CPR, for example, and you're doing your sono pulse check, and you asked somebody to do an ultrasound, and he does a subcostal 4-chamber for you, and this is what you see. There is absolutely no movement in that heart. And so based on that view alone, you can stop doing CPR. The chances of a return of spontaneous circulation are extremely, extremely low, and that's been shown in the literature, that if you have complete cardiac standstill on your pulse check, that you're unlikely to be successful in restoring spontaneous circulation. On the other hand, if during your pulse check in the middle of a cardiac arrest, you see you see a very big RV, a very big RA, and a splayed open tricuspid valve because of how big they are, then you're thinking then there's likely some degree of RV afterload increase, perhaps a massive pulmonary embolus may have caused this cardiac arrest. So this may be a clue that may be the cause of arrest that you're dealing with. Last but not least, the inferior vena cava view. So here you're still in the subcostal area. Your index mark now is pointing straight up towards the patient's head. And so with that, you're trying to align your probe along the long axis of the IVC. And you notice here, the IVC is always slightly off to the patient's right. The aorta, as you remember anatomically, has an ascending aorta, an arch, and then a descending aorta. And the descending aorta usually courses slightly over to the patient's left, just left of the midline, whereas the IVC is just right of the midline. So if you put your probe on and all you see is aorta, then what you need to do is tilt your probe over a little bit to the patient's right, and you will likely be able to see the inferior vena cava. As I said, index mark is pointing straight up towards the head so that you're aligning yourself with the long axis of the inferior vena cava. And this is what the IVC will look like. There are 3 hallmark features of the inferior vena cava. The first is that it joins the RA. If you're able to demonstrate that this structure joins the RA, then it is the IVC. The second hallmark feature is that you see the hepatic vein joining the IVC. The third hallmark feature is that it is transhepatic. The IVC courses through the liver. And the reason I say these 3 hallmark features is that you don't want to confuse yourself what you're looking at. Are you looking at IVC or are you looking at aorta? You'll be surprised how many people will confuse both when they're first starting to learn point of care ultrasound. So here, what do we use the IVC for? You can use it for volume status assessment. I will say, however, that you have to take it in context of the full exam, because in terms of volume status assessment, if the IVC looks really flat and collapsible, then it likely indicates that the patient is volume responsive. But if the IVC is not collapsed, that does not rule out volume responsiveness. They could still be volume responsive with an IVC that's not collapsible. And so I'm going to say this, take it with a grain of salt. Look at the IVC in terms of trying to assess volume status, but also take a look at your parasternal short axis and see whether there's kissing pap muscles, for example. Take a look at your lungs and see if there's A lines or B lines, because obviously if there's B lines, you don't want to give volume because they're likely not going to be too volume tolerant. Whereas if they have A lines in the lungs, that means they're likely going to be more volume tolerant. And there are other ways to assess volume status other than the IVC. The IVC on its own is not enough usually to assess volume status. The good use, I think, or the use that I usually depend on quite a bit for the IVC is to support the diagnosis of tamponade and RV failure. Now, you'd expect in case of tamponade and RV failure that the IVC will be plethoric and distended and will have no variation with respiration. And that would be one of the echo features of tamponade. One of the echo features of tamponade is that you have a big IVC with no variation. If you don't have that, then that rules out tamponade. If you, for example, you would put the probe on and the IVC is small and collapsible, that indicates that the patient likely has no tamponade physiology. And so the sensitivity is pretty high there. And you can rule out a tamponade based on this if you find that the IVC is collapsible and small. But if it's big, then it supports the diagnosis of RV failure or tamponade. And as I said, do not confuse it for the descending aorta. And here I show the descending aorta. As you can see, it is retrohepatic. It is not transhepatic. You see the liver up top and the descending aorta in the far field. You cannot see a right atrium and you cannot see hepatic vein joinet. So undifferentiated shock. When you have a new admission to the ICU, a lot of times my trainees will come and say they're presenting with undifferentiated shock. And what that tells me, it tells me that they have not had a chance to put the ultrasound probe on and try to understand what type of shock that they are dealing with. Because in the era of point of care ultrasound, undifferentiated shock is not an acceptable diagnosis. You need to be able to put the probe on and see what type of shock the patient is in. Basically look under the hood and see what type of shock you're dealing with. Here is the shock algorithm, and this algorithm basically tells you what type of shock you're going to try to find out, or you're going to try to differentiate on point of care ultrasound. If the LV looks hyperdynamic and small, then you can either be dealing with hypovolemia or sepsis, or perhaps even SAM of the anterior leaflet and dynamic left ventricular outflow tract obstruction. If the LV is hypodynamic, there may be global or regional LV dysfunction. You may be dealing with cardiogenic shock. If the RV is dilated, then you would look for RV volume or pressure overload signs. And if there are, then you may be dealing with acute RV failure, say, for example, in case of a massive pulmonary embolism. If you find that there's a pericardial effusion, you try to assess for echo features of tamponade. And if there are echo features of tamponade, then you can make the diagnosis that this is an obstructive shock due to pericardial tamponade. All right, let's go through some clinical vignettes now. So these are real cases that I have used ultrasound in, and it actually has made a difference in patient management and in patient trajectory and course. And so our first patient here is a 70-year-old gentleman with end-stage renal disease presenting for a kidney transplant. And he got his dialysis session on the morning of getting his kidney transplant. And right after induction of anesthesia, the blood pressure dropped to 50 on 30. And on the lead 2 monitor in the operating room, the ST segments started to go up. And so with inferior ST elevation, the anesthesiologist tried to normalize the blood pressure by giving phenylephrine. And once they normalized the blood pressure, they reassessed the situation, but the STs remained elevated in the inferior leads. So the anesthesiologist had a discussion with a surgeon at the time and basically said, okay, do we want to go ahead with this transplant, or do we want to basically abort the transplant and work him up for an ischemic, an ACS, and send him for coronary angiogram? Because there were persistent ST elevations on lead 2, the decision was made to cancel the transplant, and the patient was dropped off to our ICU for stabilization. So what we did is we did obviously cardiac enzymes and an ECG, and we did a point of care ultrasound. Our primary interest here is to assess for wall motion abnormalities given the fact that there was ST elevations in the inferior leads. So here we see our parasternal long axis view. We don't see much like wall motion abnormalities here. There's nothing really that jumps at us. The walls that we see here are the anteroseptal wall in the near field, and it looks to be thickening and contracting okay. And in the far field, we see the infralateral wall, and it looks to be thickening and contracting fine. So no wall motion abnormalities based on this view. Moving on to the parasternal short axis, here you see that all walls of the heart are thickening and contracting. So no evidence of wall motion abnormalities based on this view as well. Everything is moving, both like anterior, inferior, septum, and lateral wall. But what we do see in this view, however, is that the LV is underfilled. The papillary muscles are touching. There's end systolic effacement in this view, which tells me that this patient is volume depleted. Again, we see an apical 4-chamber view here, and that confirms what we saw in terms of end systolic effacement, with the LV looking like the walls are touching with each systole. And with the subcostal four-chamber view, we see here that it's confirmed. I mean, the LV contractility looks fine. There's no wall motion abnormalities. The RV size looks fine. There's no pericardial effusions. And so we move on to the IVC. And I want you to look at this IVC because this is what an empty IVC looks like. Very small, very collapsible. And remember, this patient at the time was on positive pressure ventilation. You would expect somebody on positive pressure ventilation to have a more distended IVC. Here, on the other hand, you see that the IVC is very small and collapsible. In a patient who is passive on the ventilator on positive pressure ventilation, just came back from the operating room after an induction of an anesthetic and is fully paralyzed. So this is a very small IVC. This patient is likely very, very underfilled and likely in need of volume. And we do M mode here to measure the diameter. M mode is basically interrogation along a single line of ultrasound. If you look at the line on the scout view up top, this is what we're interrogating here. And the x-axis is time, so it has great temporal resolution. And so with M mode, we can see here, we're looking through the liver, so the liver up top here, and then the IVC right below, we measured it out to be 0.6 centimeters, so this is a pretty small IVC. Now these numbers here tell you what constitutes a small IVC. So if somebody is mechanically ventilated, is passive on the ventilator, then their IVC diameter, if it's less than 1.5 centimeters, less than or equal to, then that indicates a small IVC. Remember, this gentleman had an IVC diameter of 0.6 centimeters, so that was quite small. And if somebody's spontaneously breathing, on the other hand, then a small IVC would be less than 1 centimeter in diameter. In terms of respiratory variation, if somebody's mechanically ventilated, if there's respiratory variation greater than 12 to 18%, this would be considered significant and the patient would be considered to be volume responsive. If the patient is spontaneously breathing, on the other hand, any variation greater than 50% would be considered significant and the patient would likely be volume responsive. So these numbers only apply in the mechanically ventilated patient to somebody who is completely passive on the ventilator and is not triggering breaths. So they must be actually completely paralyzed. And these numbers have been validated in paralyzed, completely passive patients on the ventilator. And these numbers have been validated in patients who are spontaneously breathing, who are extubated. So what about patients who are on pressure support? If you're on pressure support, we don't have actual numbers to guide us. What are the normal IVC values? Because as you can imagine, in pressure support, things will differ. The patient effort will differ between one breath and the other. And so these numbers have only been validated in the two extremes. Somebody who is passive on the ventilator, completely knocked out, or somebody who's extubated and spontaneously breathing. For somebody who is on pressure support ventilation, for example, we don't have actual numbers to go by. So in terms of going back to our case, this case, basically, this patient had CKs done and his CKs were normal, and his troponin Ts, the high sensitivity troponin Ts were 37 and 30, so they were not, they were elevated, but were not remarkably elevated. So certainly did not seem to have any MI. And the patient was referred to a coronary angiogram, and the angiogram did not show any significant stenosis. The LAD was only 40% stenosed, which is non-significant. We all know that the LAD and the RCA and the circ, significant stenosis is considered beyond 70%. Anything less than 70% is non-significant stenosis. So he would not be eligible for any stenting or bypass or anything like that. This is not considered significant. And he had minor irregularities in the other coronaries. And so the patient was relisted for transplant and received his kidney transplant 5 months later uneventfully. Now here, so what was happening? Why did we see ST elevations in the operating room? It was likely a demand ischemia. The patient got an anesthetic, his blood pressure dropped, and he developed a bit of a demand ischemia. And one thing probably they could have done in the operating room was potentially a transesophageal echocardiogram. Regardless, what happened there was likely a type 2 ischemia situation where it was simply demand ischemia. And so essentially this patient did not have anatomical coronary artery disease that was significant. Okay. The next case, we have a 7-year-old gentleman recently diagnosed with lung cancer. And this gentleman presents with increasing weakness and dyspnea for 2 days. In the emergency department, his heart rate is a bit tachycardic, 115, and his blood pressure is low at 85 on 57. And he presents with decreased level of consciousness. He is intubated and he started on norepinephrine as a vasopressor and was transferred to us in the ICU. So we do a point of care ultrasound, focused transthoracic echo to assess why the patient is on pressors. Any patient who's admitted to the ICU on pressors warrants a focused transthoracic echo to understand why they're requiring pressors. Now, this patient here was presenting with an intrathoracic malignancy. This was our attempt at a parasternal long axis view. And you can see here a very big hypoechoic fluid rim outside the LV. This patient had a very large pericardial effusion. And when you move on, there you go. When you move on to the parasternal short axis view, you see here that the fluid is circumferential all around the LV, and it's pretty convincing. This patient has a large pericardial effusion. This is our apical 4-chamber view. It confirms what we saw previously, very large pericardial effusion. But I want to turn your attention to the right side of the heart. Look at that right ventricle and look at specifically the right atrium, and look at the right atrial free wall. So I want you to notice here how the right atrial free wall is actually flattening out and becoming somewhat concave during diastole. So this is a sign of tamponade. There is right atrial diastolic collapse. Normally, the right atrial free wall is convex. It is not normally flat and is not normally concave. So here what we're seeing is a sign of tamponade, which is right atrial diastolic collapse. This is our subcostal 4-chamber view. You see it's very convincing here. You see the fluid all around the heart. So this patient basically was presenting with a large pericardial effusion and right atrial diastolic collapse. This is how you'd expect the IVC to look like in cases of tamponade. The IVC looks very big and plethoric, and there's no variation with respiration there. So this is one of the echo features of tamponade, a big plethoric IVC with no variation. And we measured it out, and it was 1.8 centimeters in diameter. So what did we do? So we called cardiology. I typically usually call cardiology for percardiocentesis because they do this procedure more often than we do, and it is a very high-risk procedure. Percardiocentesis are very high risk. When you go in with your needle, the RV is very close by. You usually don't have a big safety margin. And if you poke a hole into the right ventricle will start to bleed, and it will make the tamponade worse. And so because it has a very narrow safety margin, these procedures are very high risk, and I usually recommend that cardiologists actually do them. However, we were at the time at a different campus where we didn't have in-house cardiology support. We have 2 hospitals in the city, and this was the hospital that doesn't have the cardiology services after hours. They only have it during daytime hours. And so we called cardiology. They said they're en route. They'll be 25 minutes. And while we're waiting, we had the percardiocentesis kit at the bedside. And while we're waiting, the patient develops a sudden pulseless electrical activity arrest, a PA arrest. And so what do you do in this situation? Well, in this situation, you need to drain that pericardial effusion. You will not achieve ROSC, or return of spontaneous circulation, without draining the effusion. Somebody has to drain it. And I would recommend usually the most senior person in the room to drain it because it's such a high risk procedure. And so I was the most senior person in the room. I ended up draining that effusion myself. Basically went subcostally, 45-degree angle, pointing towards the left shoulder, and basically aspirating as I'm advancing my needle very slowly and aspirating with every millimeter as I advance to make sure I don't miss the pericardial effusion and I don't go too deep. And so basically ended up getting the drain in. After getting fluid back, after the first 20 cc's of fluid, the patient had return of spontaneous circulation. I put in a guide wire, dilated over the guide wire, and then put in a catheter in the pericardial space. And so the patient achieved return of spontaneous circulation by that time. And so this is our subcostal view after putting in the drain. You see here, there's a very small rim of pericardial effusion that's still there. It's not completely drained, but now we have more stability. Now we have return of spontaneous circulation, and the patient was in a better spot. Now, there are three situations where I'm usually looking for a pericardial effusion. If somebody presents with an intrathoracic malignancy like this patient, like lung cancer, if a patient has longstanding uremia with chronic renal failure, they can develop uremic pericarditis and pericardial effusions. And the third situation is in trauma patients as well. In trauma patients, they can develop traumatic pericardial effusions. You could add to that a fourth situation. If somebody has an MI and you want to assess for mechanical complications like free wall rupture, you can also find big effusions in that situation as well. How do you diagnose pericardial effusion? So, how do you diagnose tamponade? That's the more important question. If there's tamponade, then you need to basically demonstrate that there are clinical features of shock. Tamponade is always number one, a clinical diagnosis. You have to make sure that you're seeing features of tamponade, and we get taught this in medical school, and we get taught it over and over again. If there are no clinical features of tamponade, then the patient does not have tamponade. They have to have shock, high lactates, low urine output, and pulsus paradoxus. And if you have an arterial line in place, you will be able to very easily see pulsus paradoxus with variation in your waveform. In terms of echo, you need to be able to demonstrate a moderate to large pericardial effusion in multiple views. As I said, one of the major features is a plethoric non-varying inferior vena cava. You may also be able to demonstrate right atrial diastolic collapse or right ventricular diastolic collapse. Both right atrium and right ventricle collapse during diastole. However, the chambers of the heart collapse at the point in the cardiac cycle where the chamber inside of them is the lowest, which makes sense. Like if you have a pericardial effusion and the effusion is under pressure and it's compressing the heart from the outside, the chamber will collapse once the pressure inside of it is lower than the pressure outside. So the pressure inside the right atrium is the lowest during late diastole. Once it's emptied out, it's usually the lowest. The pressure inside the right ventricle is the lowest in early diastole when it first starts relaxation, right after the isovolemic relaxation phase. So here you see that both can get compressed in diastole. However, the right atrium gets usually compressed in late diastole. The right ventricle usually gets compressed in early diastole. Another feature is respiratory inflow variation across the mitral valve of greater than 25% and across the tricuspid valve of greater than 40%. This is more advanced. You would need pulse wave Doppler in order to assess for inflow variation across these valves. But what I want you to remember is that this inflow variation is the echo equivalent of pulsus paradoxus. So that respiratory inflow variation across these two valves is the echo, is what you would see on echo as an equivalent to pulsus paradoxus. So how would you treat a pericardial effusion? If you see one that is small or incidental, you observe, you follow it up, you don't need to do much about it. If the patient is unstable, then you need to temporize the patient by giving fluids to increase intercardiac pressures and temporize perfusion pressures by starting them on pressors. You need stat cardiology consult. You need the percardiocentesis kit at the bedside in case the patient crashes, in which case the patient will need an emergent percardiocentesis right then and there. Otherwise, if they're on pressors and they're relatively stable, I will usually get the cardiologist to do the percardiocentesis. And if they're obviously dying or if they arrest, then percardiocentesis needs to happen emergently. And usually the most senior person in the room should do that drain. Another case here, we've got a 48-year-old gentleman who basically tried to commit suicide. He had a history of major depression disorder and basically closed his garage door and started the lawnmower running and presented to the emergency department with carbon monoxide toxicity. And his initial carbon monoxide level was 48% in emerge. So that is 48% carboxyhemoglobin. This is a very high level. And so this patient, if you conceptualize it, he only has the remainder of his hemoglobin to carry oxygen. So out of 48%, he only has the remainder, which is 52%, to deliver oxygen to the body. So his maximum attainable saturation is 52%. You can think of it that way. And so this patient had a very high level. The treatment of choice is a hyperbaric oxygen chamber. Unfortunately, in the city we are in London, Ontario, we don't have a hyperbaric chamber. We would have to transfer them to another city, which is 2 hours away. So because we don't have it, we basically intubated the patient, put the patient on 100% oxygen, and that way you shorten the half-life of carboxyhemoglobin, because now the physically dissolved oxygen is competing with the carboxyhemoglobin for the binding sites on the hemoglobin. So basically in eMERGE, he was intubated, put on 100% oxygen. And then by the time he got an ICU bed, we repeated the gases and his carbon monoxide level was down to 12.5% without a hyperbaric chamber, just with 100% oxygen treatment. However, when he presented to us in the ICU, he was in refractory shock and he was requiring very high doses of norepinephrine and vasopressin. And so we needed to understand why he was requiring that despite his improvement on the blood gases. So we put in on the point of care, we did a point of care ultrasound, and this is our parasternal long axis view. And what you see here is the LV, and the LV contractility looks to be severely impaired. And we confirm that. We look here at a parasternal short axis, a globally impaired left ventricular function. So left ventricle is globally impaired. It's not regional. It's all down. And we are still in the parasternal short axis, and we're doing a parasternal short axis basal view. So we're looking actually at the mitral valve here in this view. And we confirm that there is global LV dysfunction. And then we go to the subcostal forechamber, looking through the liver now, and look at the LV. Again, the LV looks like it is severely dysfunctional. And this is how you'd expect the IVC to look like if you have severe heart failure or severe LV dysfunction. The IVC is big and plethoric with not much variation, and it measured about 2.4 centimeter. So essentially this patient, instead of needing a vasopressor, instead of norepinephrine and vasopressin, this patient needed an inotrope. His contractility was severely impaired. So we added on dobutamine. You could have probably added on milrinone as well. It would have worked just as well. We, in this case, added on dobutamine. And like an hour after adding on dobutamine, we were able to wean norepinephrine and vasopressin to completely off. And the patient was stable on low-dose dobutamine. And we were able, over the next few hours, to also wean dobutamine as well. And so what was happening there? Why did this patient present with low cardiac output after carbon monoxide toxicity? When you think of it there, the patient had a state of whole body hypoxia. They were not able to deliver oxygen to their entire body, including their heart. And so similar to what you see after a cardiac arrest, you see stunning, myocardial stunning. So what the patient had was myocardial stunning because of lack of oxygen delivery to the myocardium and to the rest of his body. So this stunning took a little bit of time to recover, but doing the transthoracic echo helped us tailor therapy to the cause of shock, which is in this situation, it was cardiogenic. So in terms of LV function assessment, I usually say a visual assessment for point of care purposes is satisfactory. It's expedited. It gives you the answer that you want. If you really want to get fancy, there's a more quantitative method, which is the Simpson's method of discs. I don't necessarily do this all the time. I only do this if I'm following up a patient, but I don't do it routinely. For point of care purposes, you don't necessarily need it per se. The way you do a Simpson's method of disc is that you hone in on the left ventricle and the apical forechamber, and then you pause in diastole and you measure out the endocardial borders, and then you pause in systole, measure out the endocardial borders, and then it gives you an ejection fraction here of 56%. This is a single plane method of discs. And then if you get a two-chamber view, you can repeat it again and get a biplane Simpson's method of discs, and this gives you an exact number. I will say, however, if you're trying to determine whether the patient is in shock because of cardiogenic reasons or not, you don't really need to do the Simpson's method of disc. You just need a visual estimate. Is the visual estimate accurate? Yes, it is accurate with practice. If you have enough practice looking at the LV, you will be able to estimate what the LV ejection fraction is without having to trace out the borders. And there's been multiple studies that have shown that LV ejection fraction estimation using a visual estimate is pretty accurate. And so that's what I would recommend. For point of care purposes, do a visual estimate. It's rapid, it's accurate with practice. The biplane Simpson's method of disc is time consuming, And in the emergency situation, the exact number may not be may not be very relevant. It may be only relevant if you're trying to follow up the patient and see if they've improved over time. But if in an emergency situation, you don't necessarily need to do the biplane Simpson's method of discs. In fact, I would recommend against it in this situation, just because it's time consuming and it may delay life-saving treatments. Okay, so how do you rate global function by visual estimate? You just need to basically rate it as hyperdynamic if the EF is more than 70%, normal if the EF looks normal, anywhere from 55 to 70%. If it's depressed, then the EF is anywhere from the range of 30 to 55%. If it's severely depressed, then the EF is less than 30%. And I usually will assess LV function in 2 or more views. So you need to corroborate your findings and find whether you're, there's a saying that say 1 view is a hypothesis, 2 views is real. So basically try to corroborate and confirm your findings on 2 views to make sure that your call is correct. Okay, another case here, I think this is my last case. You got a 67-year-old lady with a history of breast cancer. She presents with sudden onset dyspnea and syncope. Her blood pressure is 75/38, so she's very hypotensive. She's in shock, in emerge. She's given intravenous fluids. She started on norepinephrine, and basically we try to get an ultrasound exam. It was the emerge physician actually consulted us in ICU, so we usually go down to assess the patient before admission. We did the ultrasound to assess why the patient was in shock. And this lady, this was the view that we got before she arrested. So as we were getting this view, this was our attempt at an apical 4-chamber. And you can see here, as we were doing this view, she went into a PA cardiac arrest. You can see that the RV is huge. This is a severely enlarged RV. And there's a lot of septal shift to the left side. And so this patient had a big RV with a history of cancer and now arresting in PEA. This definitely looked to us like the patient arrested from a massive pulmonary embolism. You can see here the RV is massively distended. You barely see the LV at all. The LV is squished. It's pushed over to the side. You see, because the RV is distended, you see a little bit here, the moderator band. This is a normal finding, the moderator band at the apex of the RV, but the RV is pretty stretched, as you can see, and enlarged quite a bit. Just a quick review of the types of pulmonary embolism. And so there are 3 types of pulmonary embolism for clinical purposes. If you have somebody presenting in shock, like this lady, for example, she presented in a cardiac arrest, or if they present in shock, like as defined by systolic blood pressure of less than 90 for more than 15 minutes, this by definition is shock. Then this patient has a massive pulmonary embolism. And if you present with a massive pulmonary embolism in shock, then your mortality rate is quite high. Mortality rate is roughly from 20 to 65%. If it's a post-cardiac arrest patient, the mortality rate is about 65%. And so with that high mortality, the therapy of choice is thrombolytic, or you can do a mechanical thrombectomy, or they could basically go to the OR and get a surgical embolectomy. Regardless, this patient, if you don't intervene acutely, they will likely not survive. And so thrombolytics are usually given in this situation if they are the available option to you. If you have, on the other hand, a patient with a PE and they're not in shock, maybe they have a bit of transient hypotension, but they're not in shock, and you can see on echo that they have moderate to severe RV strain, but their hemodynamics are stable. They're not requiring pressors. In this situation, you don't necessarily, I've written here, consider thrombolytics, but I would actually be very cautious. I would probably just stick with anticoagulation in that situation. If the hemodynamics are stable, then you can watch and monitor and stick with heparin anticoagulation. And if the patient goes into shock, meaning that they are now developing a massive PE, that's when I would probably jump on giving a thrombolytic. The reason I would not jump on a thrombolytic right away in submassive PE is that thrombolytics have a real risk of hemorrhage. There's a real risk of a life-threatening hemorrhage that's in the range of about 8-9%. So 8-9% of the time you will encounter a hemorrhage from a thrombolytic, this hemorrhage could be intracranial and it could be devastating. And so thrombolytics are a very risky intervention. And so because their risk is about 8-9%, we usually reserve it for somebody who is in a massive PE where their mortality is 20 to 65%. So here, the benefits outweigh the risk in cases of a massive PE. But in cases of a submassive PE, there's a real risk. And so there is a theoretical advantage of giving thrombolytics here, is that it basically can reduce the incidence of chronic thromboembolic pulmonary hypertension. However, because of the risk, you'd need a very good discussion with family before you actually would give somebody with submassive a thrombolytic. I would generally shy away from it in most circumstances. Obviously, in cases of low risk PE, if there's no evidence of RV strain, then thrombolytics are not indicated. You just go with heparin in that situation. So let's go back to her case. So this lady got 3 cycles of CPR, got epinephrine, and got TPA in the code blue. And we had a return of spontaneous circulation after 3 cycles of CPR. She was admitted, she was given TPA on spec without getting a CT because she was basically arresting, so she had to get it. So she was admitted to the ICU, and on day 2, we did a CT pulmonary angiogram to confirm, and we did find a PE, obviously, and she was extubated in the ICU after that and discharged home on day 9 on therapeutic dalteparin. Again, going back to our shock algorithm, are we dealing with a small hyperdynamic LV? Is it hypovolemia, sepsis? Is it dynamic LVOT obstruction? Are we dealing with a hypodynamic LV, in which case you're dealing with either global or regional LV dysfunction? You may be dealing with cardiogenic shock. Is it a dilated RV? Is there signs of RV volume or pressure overload? Is there a flattened septum? Is there a big IVC? Then you may be dealing with acute RV failure. If there's pericardial effusion, then you'd look for tamponade, and you may be able to diagnose a tamponade that way. Last but not least, I want to give credit to some of my mentors, people like Dr. Robert Arnfield, Dr. Dan Bainbridge, Dr. Ivan Iglesias, and I'd like to invite everybody to visit our website. We have a website called westernsono.ca. If you visit that website, you will find there a lot of modules, a lot of educational modules, screencasts, cases, training, and you may be able to sign up for our annual workshop as well. Thank you very much. These are my references, and I'm open to all your questions.
Thank you so much, Dr. Hegazy, for this excellent lecture. You actually made a great effort to come in this way. It's very targeted and to the point, and I actually enjoyed it. I have a question for you. So how accurate is the point of care echo in comparison to CTBA in the diagnosis of PE?
Yeah, that's a very good question. So essentially, a point of care echo does not have good sensitivity nor specificity. So you really cannot rule out a PE based on transthoracic echo. When would you use it? So CTPA remains the standard. And so CTPA is how you would really diagnose a massive or a submassive or any degree of pulmonary embolism. When would you use a point of care ultrasound though? You would use it in this situation where you have a patient who's extremely unstable, who's not able to go to the CT scanner, like this patient was arresting. And so you would use it in this situation as a surrogate for the CTPA until the patient is more stable and able to get a CTPA. And what you're looking for here is RV size and RV function. If you're able to actually visualize the clot in the main pulmonary artery, sometimes you can do that. But I'd say 9 times out of 10, you're not able to visualize that. Basically, you're looking at somebody who is in the right clinical context. They're presenting with a risk factor for a DVT-PE. You find on echo that they have a big RV and they're in shock and they're too unstable to go to the CT scanner. I usually will use point of care ultrasound in this setting as a surrogate until they're more stable. I may even, if they don't have a contraindication, I would initiate thrombolytic therapy. But CTPA does remain the gold standard.
Yeah. And the second question is, how can you use the point of care echo as well in guiding fluid management in critically ill patients during shock in the ICU?
Yeah, that's an excellent question again. So I think this question has been looked at in quite a few studies. we can probably devote a lecture to that topic on its own. So fluid management is, we use a multi-pronged approach. And so IVC
Did we lose connection, Dr. Saad?
Sorry,
Oh,
do you
yeah,
hear
no
me
worries.
okay?
Yeah, you're fine now. We hear you.
Okay.
Yeah.
Yeah, it said here my
Yeah.
internet connection is unstable. I apologize
Oh,
for
no
that.
worries. Yeah.
So essentially a multi-pronged approach. So how does ultrasound help? You can do basically an IVC assessment. You could look at, as I said, a parasternal short axis and assess for end-systolic effacement. You could look at the lungs for A lines and B lines. You could look at LVOT flow variation. So you could look at the left ventricular outflow tract. You'd need an apical 5-chamber view, which we didn't really cover in this lecture. And you could put pulse wave Doppler in left ventricular outflow tract and look at flow variation across left ventricular outflow tract. And if it's more than 15 to 20%, that usually indicates volume responsiveness. And so these are all ways to assess for volume responsiveness in the ICU. The gold standard, I guess, remains a passive leg raise. Despite how simple that test is, most studies that have looked at assessing volume status have compared that to the passive leg raise test, and that they assess the response to that on hemodynamics and on echo and on basically filling pressures.
Okay. From the question box, Dr. Burhan Kazal, does the American Heart Association, American College of Cardiology accept sono pulse check as a guidance or a guideline to stop resuscitation in cardiac arrest?
So there have been publications that have shown that if you have zero cardiac activity, like a cardiac standstill, that the rate of a return of spontaneous circulation after that cardiac arrest is very low. However, it's not zero. So it depends on the circumstance. If you're potentially doing it for 30 minutes and you're not getting any return of spontaneous circulation, and you look and there's complete cardiac standstill, the chances of ROSC are low. Does the American Heart Association accept that as a criteria? Last I checked, they do not mention it as an explicit criteria. So they don't, I don't remember them actually explicitly accepting that as a criteria for stopping. So at your discretion, you may want to continue if it's a younger patient and you feel like they may still recover. I must say, though, the chances of recovery are extremely, extremely low if that's what you see on the pulse check.
Thank you. So another question from Dr. Hossein Al-Zanati. Thanks for excellent presentation. Please, sir, is pericardiocentesis effective enough with cardiac tamponade, even when with expected clotted blood?
Yeah, so if the blood is clotted, then it may not be effective. You may need actual surgical evacuation through a
Pericardial window. Yeah.
Pericardial window. So yeah, definitely. If there's organization, if it's an organized clot, or if there's actual clot in there, pericardiocentesis may not be the way to go, in which case you would have to get a surgery consult. If it's circumferential and it's clear fluid, then yes, pericardiocentesis would be the way to go. Now, mind you, this is all for medical patients. I'm not talking here about post-cardiac surgery patients. Obviously, post-cardiac surgery patients, you never do a pericardiocentesis in these patients. If they have tamponade, they need to go back to the OR for an evacuation.
Yeah. Thank you so much. And I think Dr. Saad would like to say something.
There is a question from Dr. Ahmed Amin Nas.
Yeah.
Dr. Ahmed.
Yes, hello. Thank you so much. Actually, very congratulations for this scholar presentation of Dr. Hegazy and skillful intervention in cases of the cardiac tamponade. However, my question is regarding the 5-month delay before renal transplant. Is that because of any clinical suspicion of something, or it's just the logistics of rebooking the case? Thank you.
Yeah, thank you. There was just logistics really, because a lot of the transplants in Canada are cadaveric or basically after donation after cardiac death or donation after neurologic death as well. So we don't have a lot of living related donations. And so basically it was just logistics of him getting a suitable kidney after he was relisted.
Well, thank you so much.
No worries.
Cheers.
Another question from Dr. Mu'tasim Mahdi. Is there any online course on point of care sonography?
So yeah, so there are, if you go on our website, westernsono.ca, it will link you to the CRUS course. The CRUS is the Canadian Resuscitative Ultrasound course. That is a potential course that we are looking to try to provide online now, given the COVID restrictions. This is in the works. We usually do this course in August, and so we'll see what happens. By the time August comes, we may be able to offer it in person, in which case we won't do it online. Now, I'm not sure what the others do. You may want to check the WinFocus website, for example. I'm not sure if anybody in the audience knows of online ultrasound courses that are purely online. That would be something that perhaps the audience can help me with.
Can we take a promise from Dr. Ahmed Hegazy? He will contribute a little bit more ultrasound point of care education and echocardiography, please, for the MEGA attendees and the MEGA fan here, because we have 77 countries, looking for education from the MEGA learning.
Yeah, sure. I'd be happy to.
Thank you so much.
Last question from Dr. Hussein Al-Zanati. So what are the criteria for stopping CPR more than 20 minutes with continuous asystole after correction of all reversible causes, the 5H and 5Ts?
So after you've corrected the 5Hs, 5Ts, you've ruled out anything that's reversible, and you're still beyond 20 minutes and you're still doing CPR, what are the criteria for stopping? That's actually a very good question. And I must say it is very, very situation specific. So if you don't have any reversible cause and you've basically exhausted all your attempts at reestablishing maternal spontaneous circulation, then it's unlikely that you may, like, basically, if you want a rough ballpark, most of the time here in Canada, if I'm in the ICU, my CPR will be anywhere from the range of 20 minutes to 45 minutes at the most. I usually don't go beyond 45 minutes just because they're likely going to have severe neurologic injury if you keep going on for CPR for too long. However, so what are the criteria? I don't think we have definite criteria to stop CPR. I think it's very situation specific. Most of the people online here are intensivists. If it's an elderly patient who's comorbid and they're unlikely to have a good quality of life, you may want to stop earlier. If it's a younger person and you think they have a chance, you may want to continue doing CPR, potentially even until you're able to put them on extracorporeal support. So when do you stop? It's really your call. It's really in your judgment. When you think, okay, is it reasonable to stop? One thing I usually do as well before I stop is, if I'm leading the code, I'll look out to the team around me. Okay, guys, any other ideas? Anybody want to add anything? This is the last round of CPR. Anybody have anything they want to contribute? And so that's just sort of to improve collaboration, but definitely you need to have clinical judgment rule on that one.
And you may also say at the end, is everybody in the team convinced that we have done everything for the patient? So some other people may come with another idea in different words. So that's why it's a consensus from the whole team that we need to stop, because there is no more progression can happen.
Yeah, that's exactly right.
Yeah.
So it is excellent teamwork tonight. I really am so overwhelmed about the professionality, the amount, and the kind and the quality of educational material, the punctuality of the webinar tonight. Special thanks to Prof. Hidalgo, Dr. Ahmed Hegazy, our excellent moderator tonight, Dr. Yasser Reda, and Dr. Ahmed Abdulati. A special thanks to all professors and panelists to support us tonight, Dr. Sahar Marzouk, Dr. Ines Kamel, and Dr. Ala Salama from Switzerland, and my colleague in European Diploma examiners, and Dr. Ain Al-Marwa from Cairo, and everybody around the globe supporting us tonight to attend this webinar.